Myself here. All right. Hello, my name's Julie Buckle, and as Diana said, I'm with Geriatric Connections, a home-based counseling agency. So we started 15 years ago because we were able to recognize that although it is not a normal part of aging to experience depression, anxiety, or difficulties, we also know that as we get older, there's more experiences and more changes in life that can bring on experiences of depression, anxiety. And not everybody is able to get out of their home and go to a counseling agency. So we come to people who are not able to come to us. And we actually don't even have, should I get on the microphone?
Can you hear her okay?
Okay, if you can't hear me, just let me know and I'll pick that back up. So anyways, we're there for people who are not able to come to us. We don't even have a physical office. So we only drive to people's homes where they're at to provide services. So that's what I do. And another part of what I do is come out and I talk to groups. I talk to community groups, I talk to professional groups. I do that throughout the state of Michigan. So today we're going to talk about feeling the blues and the blondes, because when Diane and I were talking about, well, what should we name this? It's like, what's it about? It's like feeling blah, right? And sometimes we just feel blah. And depression and anxiety are not always clinical, what we call clinical. Sometimes you just feel down. Sometimes you just have a period of low motivation. Or for some people, you might be feeling irritable. I don't want to be around people. Or I don't have energy. Just don't feel like doing that. I'm procrastinating a lot. It does not necessarily mean that you're clinically depressed or you're clinically experiencing chronic anxiety. So there's things that we can do to kind of get ourselves through these difficult times. But as Diana said, understanding what you're experiencing from a clinical level or what you're just experiencing from a normal, this is kind of something we all go through, that can be helpful too to know, do I need extra help? Do I need just to do things a little bit differently or think about things a little differently? That can be what helps you get to the next level that you want to be at. Okay? So that's what we're trying to do here today. And one of the things that I do with my presentations is I try to fit things in that are just a little pictures and little things that demonstrate or sum things up. So you're going to see a lot of these in the presentation just because sometimes it helps to like, oh, that sounds like me, or that sounds like my neighbor or my mom or whoever it may be that you're worried about, okay? So depression versus the blues. Like I'm saying, not all depression is clinical, but we identify as something that needs intervention, okay? Clinical depression has to meet criteria, last at least 2 weeks. So every day you're feeling a certain list of symptoms, which we'll get to on another slide. Feeling the blues usually just last a few days, maybe a week. The intensity is people with depression, they're often having their daily routine or their daily way of experiencing life is interrupted. It's affected by how they feel. Feeling the blues, people just they work through it. Maybe you don't go to church, like I'm sick, I can't make it to church, and you just lay around for a day, right? That's different from being clinically depressed. So the signs and symptoms of clinical depression, this is what you talk to your doctor about. This is what you've tried to get out of. You're hoping that it would just kind of go away, and it really doesn't. It kind of lingers. So you would notice at least 5 of these symptoms occurring most every day over a 2-week period of time or longer. So as you can see, agitation, restlessness, and that when we're older, sometimes we misunderstand that from I'm feeling achy, right? It's hard to get comfortable. That can be different from someone who's younger, who they may say things like, I feel like I'm crawling out of my skin, right? Changes in appetite. Some of us say, wouldn't that be nice if I wasn't hungry? For those of us who experience, eating, munching when we're feeling down, it's not such a good thing. Our weight goes up. But you're looking at like a 5% change in body weight over like a month to 3 months. So that would tell you my appetite has changed. Difficulty concentrating. So sometimes people are experiencing depression and they're really worried that they're experiencing dementia. I think I'm losing my mind. I can't remember anything. I walk into a room, I forget what I'm there for. Or I'm thinking of something and I lose concentration. Well, with 4 other symptoms, that might be a depression instead of dementia. That's something that a professional can help you with, making the distinguish between. Fatigue and lack of energy. Again, a lot of people will say, well, that's because the weather is changing. It's March, and I have arthritis, so that makes me feel fatigued. And maybe it is. But again, that's why we look at all of this put together. Feeling hopeless and helpless, feeling worthless, being more critical of yourself, feeling guilt. If a lot of people are saying you shouldn't feel bad about that, and you still do, that might be a moment to pause and say, why am I feeling bad about something when I have people around me that have a different take on it? So maybe I shouldn't be feeling guilty. Maybe I need to understand why I do. Inactivity or withdrawal from usual activities. Of course, the senior center is a great place to have a connection, but it could be for a lot of things. I used the example earlier. I'm not going to go to church today because I'm not feeling up to it. I don't have the motivation, right? But if church is something that's important to you and you feel yourself pulling away, that might be a red flag for you. Thoughts of death or suicide. This is another one where a lot of people who are older don't want to bring it up because they don't want to be put away. I've had so many people over the years say, I don't want to tell you something because I don't want to be in the hospital, right? And there's a fear that if you say, I think about dying, or I think, wouldn't it be nice if I went to sleep and I didn't wake up, that people are going to think you're crazy or you need to be somewhere. And what that tells me is you're having a lot of pain, physically, emotionally, spiritually, any combination of, and you're feeling hopeless. And you're just wanting to get away from the pain. That's not a time to get locked up, right? That's a time to start working on it. And what can we do to make being alive better than wanting to be dead? So those kind of thoughts are not active suicidal thoughts. Now, if you were to tell me, I've thought about how I'm going to kill myself, and I'm planning on doing that sometime this week, and I've had people say that. That's a whole different level, right? We don't want you to ever get to that point. There's a lot of help that comes before them so that you don't have to get to that point. But when people are there, especially men over the age of 70, men over the age of 85, if they talk about killing themselves, and if they have a firearm, you gotta make the call to get them protected. Because men over 70 and men over 85 are the 2 top age categories for completion of suicide. And the majority of time it's with a gun. So I'm not saying that to frighten everybody. I'm saying that because it's a very real risk. And if someone, especially an older man, is saying that they want to kill themselves, we need to take them very seriously and get them help and get the guns secured, okay? Just so that there can be enough of a time where we can get them the help. Other thoughts or other issues, trouble sleeping or sleeping too much, and psychotic symptoms. So someone's hallucinating or they become paranoid. So these are the signs and symptoms of clinical depression. Okay? It can be very severe. It can be more passive. Everybody's different. The good news is there's treatment for every level, and we can help people feel better. So I liked this. This is about anxiety. It's saying having anxiety and depression is like being scared and tired at the same time. It's the fear of failure, but no urge to be productive. It's wanting friends, but hating socialization. It's wanting to be alone but not wanting to be lonely. It's feeling everything at once, then feeling paralyzingly numb. And people who experience depression and anxiety will say this in multiple ways. This is what I want, but I just can't do it. That's part of the depression. That's part of the debilitation. So again, there's treatments that we can offer people so that they can feel better and they can want to do things. Anybody ever see those commercials for an antidepressant and then they say, if you have thoughts of suicide, contact your doctor? And has anybody ever wondered, why would they give you an antidepressant if it's going to cause you to think about suicide? I've got the answer. The answer is because depression and anxiety often go hand in hand. But before the medication Prozac, and Prozac came out in the 80s and early 90s. Anybody ever remember Prozac? Mm-hmm. Yeah, it was like the wonder drug when it came out because it actually had really good clinical outcomes. People who were depressed, who took Prozac felt better. Then we started having more antidepressants, something called an SSRI, serotonin reuptake inhibitor. That's the classification of medicine. And more of them came out, and we noticed that people who took the medications had higher rates of suicidal thinking and actions. That's why the warning is on those medicines. The reason they found is because people were identifying symptoms of depression. Do you remember feeling tired, feeling hopeless, feeling helpless, not having motivation? So we treat those symptoms with a medication. I've got more energy. I've got more motivation. I have a lot of anxiety that we did not recognize because I was so depressed. And now my anxiety is something that I can't get away from. And now when I have thoughts about I need to get away from this pain, I've got the energy and the motivation to do it.
Are you saying the SSRIs are better than the Prozac? I didn't quite understand.
So Prozac, the classification it's an SSRI.
Oh, it is.
It is an SSRI. So the idea here is what we learned, because we always learn things as we go, was the medication was so good to treat depression that we were not recognizing the underlying anxiety that a lot of people had. And so the symptoms of depression lessened, and then they had the energy to follow through on suicide.
Is Prozac still being used?
It is. It is. It's a very well tried and tested medication. It works for a lot of people. I don't know of any medication that works for everybody, and I don't know of any medication that does not have side effects. We're all different. In college, I worked at a pharmacy and up in Kalamazoo, and at the time, the pharmaceutical company up there was Upton Pharmaceuticals. And a lot of the pharmacists that worked in the little mom and pop pharmacy that I worked at, they worked full time at Upton. And they would just kind of keep their skills, behind the counter up at the mom and pop shop. And I had a few of them. So these were high-level pharmacists, right? These were the guys and the gals creating new formulas and new medications. And they would talk about, what clinical trials look like and how new medicines came in. And one of them told me that part of the reason why the side effect list is so long is because when they're trialing a new medicine and they try it with humans write down everything they experienced during that trial. So like last week, I had a cold. But if I was on a drug trial, I would have to write down all of my symptoms. So if enough other people had colds during months or even years that a medicine's being trialed, they have to write down. Well, it's possible that you would have sneezing, coughing, sore throat, right? Even though it was just a cold. But we don't know that because it's a new medicine, so they have to put it all together. So these are some of the exciting things that we learned through medicine. Okay, just another slide here talking about depression and how the emotions, the mind, the behavior, and the physical kind of come together. The idea here is just understanding depression is complex. It's not just I feel sad, I feel tired, I don't want to be around people. It doesn't just affect us emotionally. It affects us in other ways. This is why when people say to someone who's depressed, well, just think about happy things. You'll get through it. It's not that simple because it's very, very complex. Understanding aging and mood is also something that we want to do because, as I alluded to earlier, depression and anxiety look different in people who are older than people who are younger. Everything is different when we're younger, right? Everything's different when we're older. We've got a lot more experiences. The older you get, the more experienced you are, the more connections you have. Maybe you've developed other health issues along the way. Maybe you're taking certain medications for other things. This all kind of combines together, and it's what you experience. For people who are younger, they don't have as much reflection. They can't say, well, I've had this before, and this is how I got through it, right? Or I remember when my grandma had this, and this is how she got through it. Well, they may not have had those experiences. So things look different as we get older. There are things that can cause changes in our mood as we age. People have said, is depression and anxiety a part of aging? And kind of like what I said earlier, it's not considered a normal part of aging. But we do have higher incidence of depression and anxiety in people who are older. And by older, I mean over the age of 60. And there's a lot of complex reasons for that, which we're going to touch on. Does depression and anxiety present differently? Yes. And when do you seek out help? So we're going to look at these questions after this. This is hard to see, but it's the truth about depression. And it basically, some of the information is 1 out of 4 people at any one time can be clinically depressed. So if you're in a room, probably the statistics tell us that out of every 4 of us, 1 of us is clinically depressed. That's a statistic that's been pretty tried and true for at least 20 years. Anxiety and depression go together oftentimes, but we don't always recognize they're both there. Sometimes we just recognize one and not the other. Then when you fix one, then the other one all of a sudden shows up because we didn't realize it was already there. Depression can last for years. It can last for days. Right? Again, it just depends on the tools that you have, the abilities you have, and everything that's going on with you physically, emotionally, spiritually, environmentally. Depression, you can get better. There's multiple treatments. There's medication, there's self-help. So these are the things that we do differently so that we can feel differently. There's counseling, people like me. And there's behavioral therapy, which is kind of like a combination of self-help and counseling. This is where things are done differently. So maybe you seek some help to learn how to do things differently, and then you apply those strategies. What can cause changes in your mood as you age? Biological factors. Sometimes the reason people are feeling depressed or anxious is because there's something going on with their body physically, biologically. Low levels of neurotransmitter chemicals in the brain. Serotonin, norepinephrine. So serotonin is the feel-good chemical, right? This is the one where they say go outside in the sun so you can get serotonin, because sunshine can increase your serotonin production and you can feel better. Yes?
Isn't SSRI part of serotonin?
SSRIs, yes. Serotonin is definitely the reuptake inhibitor. Yeah, those medications target our serotonin levels in our brain. So yes, Prozac is an example of you take that medicine and it increases the production of serotonin in the brain. Because sometimes our levels are low. Sometimes we have a history of depression and anxiety. It's interesting on this one because the question is nature or nurture. I don't know if anyone's ever heard that phrase. a lot of times it's in regards to raising our children. You know, are they successful children because of the way that they're raised in their environment? You know, the nurturing part? Or is it nature? Were they just born smart? Were they born with good decision making? There's always been that debate. The same thing happens with depression and anxiety. Sometimes it's because of our environment, what we've learned or not learned on how to deal with challenges, problems, pain, loss, right? And sometimes it's, I have lower levels of serotonin, and that's just a biological family connection, something your doctors help you with. And then, of course, unresolved issues related to traumatic life events. Sometimes when I'm working with people, they might have dementia, mild to moderate dementia. And the things that we're working on are things that happened earlier in their lives, but that's where they believe they're at. And so even though they have dementia, we work on, you know, Dad did bad things to me, or I was in a car accident and I couldn't work after that. Because for them, they're experiencing it in the moment, even though it happened 30, 60 years ago. Sometimes we're dealing with traumatic events and the person has no dementia. It's just 60 years ago this happened and it wasn't resolved. I didn't remember it. It's coming back at me now. Or I knew it happened, but I was always so busy with work and family that I didn't really put a lot of effort into dealing with it. But now that I lead a quieter life, these thoughts keep coming back to me, right? And so as I have these thoughts, I have these memories, they change the way the chemicals in my brain are working, which changes the way that the chemicals in my body work, and I feel bad. Other things that can change our mood are complications associated with aging can include limited mobility, isolation, just knowing that we're closer to dying than we are being born. Transitioning from work to retirement. A lot of people talk about this is a good thing, and then they get to retirement and they're bored, right? This isn't what I thought it would be. Or the money, I've been living on my work income, and now I'm on my retirement income, and it's not as much fun, right? So these things happen. Substance abuse. It's interesting talking to college students and talking to them about substance abuse in people who are older, because a lot of them think about their grandma and grandpa. And then I remind them when Woodstock was. And then we do the math. And then we realize that grandma and grandpa could have been at Woodstock. So not everybody gets past that. You know, sometimes some of these things continue. Anyways, of course, there's loss of loved ones, widowhood, divorce, and then chronic medical conditions. These all contribute to how we feel emotionally. There are 5 brain chemicals, right? We talked about serotonin. I identified norepinephrine in the one. So serotonin, dopamine, glutamate, norepinephrine, and the GABA. So I don't know if you guys can see all these. Okay. So serotonin aids in memory and learning and contributes to feelings of well-being and happiness. Like I said, serotonin, the SSRI medications, that serotonin reuptake inhibitor, that targets increasing the serotonin levels in our brain. Dopamine is associated with the brain's pleasure and reward center, and it's linked to motivation and memory. So people who have lower dopamine levels are usually people who don't hear things like, "You look nice today, good job." Or they don't experience thoughts like, "Man, I got that garden in. It was really hard, but I did it. Yay me." If people are not getting rewards in life, your dopamine level is not being fed. And so if you're not getting those rewards, you can't feel good about it. Glutamate helps with cognitive function, alertness, memory, and learning. I don't know about any of you, but when you know what you're trying to say or think of and it won't come, and the frustration, and when we live alone, when we don't socialize, and the last 2 years has been a lot more isolation, this is really an area where we see contributions to depression and anxiety. The more isolated we are, the more difficulty we have with alertness and cognitive functioning. We're human beings, we're social beings. We benefit from interaction. If we don't have that, our brain chemical is not creating the different chemicals that we need to feel good about ourselves. Norepinephrine assists in the fight or flight, so this is really connected to our anxiety. And helps moderate our mood by alleviating depression and anxiety. So everybody's heard of fight or flight, right? And a lot of times we think about it in crisis situations. I'm walking down the path and a bear's coming at me. Okay, am I going to stay and confront the bear, or am I going to hoof it out of here, right? Or am I going to be saying, is it a brown bear or a black bear? I know one you lie down or one you run. I can't remember which one, so then the panic sets in. But norepinephrine, the fight or flight, is also things that happen every single day, okay? So my kids call me, and they're critical of the decision I'm making with my money. You shouldn't be buying that new couch. You need to save your money. What if you need it, okay? If I say to them, you know what, this is my business, this is how I'm handling it, appreciate your concern, but no. That's my fight. If I say, oh, I'm really sorry, okay, oh, you know what, the stove just went off, I gotta go get dinner, okay, I'll talk to you later. That's flight. Our fight and flight response comes in every day with every decision we make. Are we gonna confront something? Are we gonna deal with it? Or are we going to step away from it or let it happen? Part of our decision making comes from whether we are using our fight or our flight. Just a little interesting. All right, and then the GABA acts as the main inhibitory neurotransmitter and helps increase feelings of calm and relaxation, reduces stress and pain, and improves sleep and concentration. So this is really good chemicals to have, right? When we're feeling anxious. We want to calm down, we want things to go better. If these chemicals are out of balance, we're out of balance.
So on these 5 chemicals,
Yes.
you had mentioned something about depression being kind of hereditary.
Yeah.
I don't know if you
Yeah.
worded it that way. So are some people born with different amounts of each of these?
Yep. Some people have a higher incidence of heart disease in their family because it's a hereditary trait. Some people have changes in their brain chemistry that they're not balanced, which can be a hereditary trait.
What is that blue one? I can't tell what that is.
Glutamate, Glutamate. Yep. So they're just
Julie,
yes.
I think she has a question.
Oh, sorry.
How does the doctor determine if your serotonin, epinephrine, and all that is out of whack?
That's a good question. And it depends on the type of doctor you go to, and it depends on what's available. So
There isn't a blood test?
well, there can be. And so it really depends. A lot of times people, the first time they talk about depression or feeling down, or, man, I just kind of don't have a lot of energy, I've heard a lot of primary doctors say, well, let's try this, get you a little pep in your step, right? And usually what I see happen is they give an SSRI. Let's start with what works for most people, okay? We're gonna try a Prozac or a Wellbutrin or something along those lines. And then if it's, hey, how you doing? Is that helping? Yeah, a little bit. Okay, we'll leave it there. What I'm going to encourage everybody to do is, if you feel a little better, if the doctor tries you on a medicine and you feel a little better, let them know you feel a little better. But if you don't feel like you want to feel, keep the conversation going. Because the doctors can always increase the dosage. They can also change the medicine, because maybe it's not a serotonin issue. Maybe it's a norepinephrine. Maybe it's a dopamine, right? And so there's different classifications of medicine for these different things. So if it's not working for you, really have that honest discussion with the doctor so they can understand, I feel a little better, but this is also what I'm experiencing. So yeah, I've got a little bit more energy, but I have trouble sleeping, and I oftentimes feel guilty, and I have no motivation. I don't want to do stuff. People piss me off all the time, right? Irritability. That may be the clue to the doctor, oh, we don't need an SSRI. We need an SRNI. I know. But they've got a whole catalog of different classifications of medicines they can try. Now, another thing to do would go to a specialist. So a neurologist or a psychiatrist or a mid-level, so a physician assistant or a nurse practitioner who has training in mental health, and talk to them. Because they have, again, as a specialist, they have a broader understanding of medicines and how the brain works. They also have more access, because it's their specialty, to certain blood tests, because some blood tests do show things. Sometimes they have this thing that's been around for a few years. They swab the inside of your cheek and they send it to a lab. And the lab says, these are the medicines that this person's cheek swab indicate is going to be most effective. So there are some high-tech things out there. Worst case scenario, trial and error. Try this medicine, maybe go up in dosage if it's not strong enough for you, or try a different type of medicine. But it's really about communicating with your doctor. Yeah. Okay, depression in the normal brain, basically it's just talking about these chemicals again. Normal brain has a regular sized hippocampus, so that's a little tiny part of the brain, part of your brain, and like through here and down there. You'll see another picture in a minute. While the depressed brain is shrinking in size of the hippocampus, so it gets smaller. And the depressed brain has an abnormal number of neurotransmitters. So the neurotransmitters is what sends the signals to our brain, how we react to things, how we feel about things. Here's our big old brain, right? There's the hippocampus. Straight down, straight over, kind of in the middle, right? The reason I have these up here is just to demonstrate depression is not just about your mood. There is a biological chemical reaction that's occurring inside of our brain that is contributing to the way that you feel. Okay? Nobody is at fault for feeling depressed. It's not because anyone's done anything wrong. And it's important to understand that. This is something that needs the right treatment. We kind of talked about this a little bit, so I won't go into it in too much detail, but how depression can look different in the older brain compared to the younger. And you can see sadness, feelings of worthlessness, the irritability, the fatigue. You can see how some of these things can be confused for physical ailments or, the aging process. Depression anxiety is often the cause of physical pain in older adults and is not explained by other medical conditions. This is why a lot of people who are older are not diagnosed as depressed or anxious because, oh, you have arthritis, that's why you feel achy. Well, it also may be because you're not moving, because you're depressed, so you're sitting down a lot more, and your body's not moving. And it may be because the neurotransmitters in your brain are signaling to the different neurotransmitters, or the transmitters in your brain are signaling to your body parts and sending feelings of achiness. Okay? You really want to make sure you have a good assessment by a professional. Again, symptoms, kind of put a lot of these in here. I just thought they were really good slides. Irritability is a big one. I hate to say it as we get older. You remember the old stereotype, the grumpy old man, right? He was probably depressed, right? He was irritable. withdrawal, people who pull away. No, I don't feel like going out. I don't feel good. I don't want to do it. And they don't. And it's really hard because you know, well, if we can just get you out the door, you're going to have a good time. But getting out the door to someone who's really depressed is like climbing a mountain. It's overwhelming. And there's a cycle to it. It's all connected. You feel worried or stressed, so you don't sleep so good. So you're tired. So you have difficulty making daily life choices and dealing with life. So you don't feel good about yourself. So you're worried about things. So you don't have good sleep. See how it goes? Right? It is. It's a very vicious circle, and it's a downward spiral. And so often people get to the bottom, and then you have to come all the way up because it was so difficult to ask for help. Or you thought, or they thought, it's part of aging. Okay? If you're experiencing these things, if you know someone who is, the best thing to do is to start having that conversation with their doctor, with a counselor, with their spiritual guidance. You know, whoever it is, whoever can help them start working on these feelings and these experiences. There's no single cause of anxiety, depression. We kind of covered that. But research does link the genetics, the biological, the social, the psychological factors. They all kind of come in. So when I'm talking to people, we don't just treat, in counseling, it's not about treating one part of the person. We're made up of a spiritual, we're made up of physical, and we're made up of emotional cognitive, right? If one of these areas is hurting, if one of these areas is suffering, it's going to start affecting the other two. Okay? So if a person is feeling down, for whatever reason, they're feeling depressed, and they have a strong faith, and they're connected to a faith community, and they're able to stay involved with them. And physically, they're doing okay. You know, they're able to get through and do the things that they want to do for the most part. Then chances are they're going to be able to get through that depression a little bit easier, a little bit faster, because the other two parts of them raise them up. But what about the person who's feeling depressed and they have chronic health issues? Well, now 2 out of the 3 are pulling them down. And what they have is their strong faith. But I used it before, the example of, it's time for church and I'm in too much pain. Maybe it's physical, maybe it's emotional, maybe it's both. But now my one strength is being pulled down as well. And this is what we see. This is that downward spiral. The things that held me up, that helped me get through the difficult times, now is being overwhelmed. And that's where it's really difficult because we go down. You guys having fun so far? That's great. The worst kind of sad is not being able to explain why. And has anybody ever said that? What's wrong? I don't know. I just don't feel it. Well, what's going on? I just don't feel it. Yeah. One of the hardest parts of life is deciding to walk away or try harder. Fight or flight. I put this in here, and it's just kind of one of those things that's always good to know. If you or somebody else does have thoughts of suicide, of not only do I want to go to bed and not wake up, I'm going to take a bunch of pills so it happens, right? 24 hours a day, 7 days a week. This phone number and this website are available. So it doesn't have to be the person who's experiencing those thoughts, but that might be your first call. That might be someone I know is thinking about suicide. I don't know what to do. And they will talk you through that specific situation, because every situation is different. They'll help you out. Of course, there's always 911. If somebody is in immediate harm, 911. Because they're going to help you get help, right? And that's the idea of it. So what's in your control in regards to your mood? So now I've taken the topic of depression and anxiety and I've bummed you all out, right? There's all of these difficulties, these challenges. But we have the ability to influence how we get through and how we deal with these emotions. We have the ability to focus our mind as best as we can on the things that can help us improve. Okay, this is something we can do. Sometimes when I'm working with someone and they have extreme depression or extreme anxiety, they may not be able to focus, literally keep their mind focused for more than 20 seconds. And so that's where we start. All I'm asking you to do, I will say to them, is for as long as you're able, I want you to focus on what is something you're grateful for today. Find one thing you're grateful for. Just find it. Try not to use what you said yesterday. Come up with something new. It can be something as simple as, I was able to stand up from the chair today. That's something to be grateful for. We don't think about it that way a lot of times. We think about, well, yeah, I might fall over. Okay? It's the same experience, but it's how you look at it. Am I grateful that I can stand up sometimes without falling over? Or am I focused more on, I could fall over? Because the way we think about things, our perspective, have a significant impact on how we feel. When, how, and who do you share what you're experiencing? It would be extremely difficult to go from being clinically depressed and anxious to not all by yourself. It's nobody's fault if they experience depression. It's nobody's fault if they have anxiety. It's not something to feel ashamed of, even though many people do, right? It is a normal experience that humans have. We will get through it faster, better, stronger when we have people who support us. Who you have one person, it'd be great if you had more, but if you had one person who you could contact and say, I'm feeling so down today, I just don't know what to do. If you have one person who will say, I'm here with you. I'm really sorry you're going through that. They don't have to fix it for you, right? And you can tell them that. I don't need you to fix this. I just need you to be by my side. If we have one person who we feel we are supported by, that's going to help us get through it. Knowing that reaching out is a strength, not a weakness. So maybe you're calling that suicide hotline. Maybe you're reaching out to your pastor. Maybe you're calling a counseling agency. Okay? That takes a lot of guts. It takes energy, it takes thought, and it takes the ability to say, this is a pain that I don't want to live with. I want to do something about it. Just like I would if I broke a wrist. If I broke my wrist, I wouldn't say, well, if I just think about it differently, it'll get better. It might be crooked, but, all right? Why go through that pain? Emotional pain, physical pain, spiritual pain. It all hurts. If you're going to take care of your physical self, if you're going to take care of your spiritual self, why not take care of your emotional self? You're not alone with how you feel. Many people have depression, anxiety. This is not to say that what you feel does not count. This is to say that you're not alone. Human beings get depressed. Human beings have anxiety. You don't have to be alone. You don't have to feel that you're somehow the only one. This is something that we all go through. Let us help. When your focus becomes your beliefs, be kind to yourself. So what I mean by that is, what I was talking about before, how you look at a situation. If I believe standing up from a sitting position is an accomplishment, when I have a bad back or I have bad balance or I just don't have the energy to get off the couch because Jeopardy's on, and after Jeopardy is on, I got another show, and then I got another show, and then it's time for bed, right? But if I say to myself, sitting on the couch and not moving is contributing to my depression, I'm going to stand up every time a commercial comes on. And I'm going to have my walker next to me, and I'm going to make sure that I think it through, put my feet, shoulder width apart, make sure that when I stand up, I keep my head up, that I'm not looking down to fall down, right? Go through the steps, even though I can't believe I have to think about standing. I accept that. So I stand up, take a deep breath, and realize that I'm focusing on improving myself. And that's a good thing. Your focus becomes your beliefs, and you have to be kind to yourself. That's how it works. I love these ladies. Don't grow old, grow awesome. All right, 10 tips for mental wellness. And I'm sorry that the slide did that. The first one says, connect with others, socialize, hint, hint, senior centers. Right? Stay positive. This is something that came out of some research. Research has told us that if you say things that are positive, if you smile, even if you don't feel happy, the chemicals in your brain, serotonin, dopamine, norepinephrine, increase. You can literally trick your brain into creating the good feeling chemicals by saying, it's a beautiful day today. I'm glad to be here. I'm going to smile. Right? Smiling creates good chemicals. So why not? Practice it, right? Get physically active. You don't have to be Jane Fonda to move, right? So you don't have to be bebopping around and all of that. Sometimes movement is simply, I've got Jeopardy. Well, I'm going to turn on the TV. Well, I'm going to use that hand, and I'm going to change the channel. And I'm going to see if I can do it up there. And I'm going to see if I can do it down here. And I'm sitting on the couch, and what I've just done are stretches. And I had a psychiatrist tell me that anytime we move our arms over our heart level, we create good chemicals in our brain. So, just let you know. Yeah, bring it on. Bring it on.
Let's all do that now.
That's right. There you go. There you go. Yeah. And that's activity. It counts, right? All right. Help others. All right, go back to that one slide that said about doing good things, right? Financially, emotionally, physically, spiritually, socially. It can be any category. Calling somebody up who you know can't get out of the house just to say, hey, I've been thinking about you. That might be the best thing that they've had happen all day, and the fact that you did it could be the best thing that you've done all day. Doing for others is a huge positive, good, healthy chemical production process. Okay, it's the sleep thing. And I know sleep is a difficult activity for many of us, right? But getting enough sleep is really important to good well-being and mental health. So what I'm not saying is go to sleep at this time and wake up at that time, and you've got 7 or 8 hours in between, and you managed it okay. What it's saying is get enough sleep. Sometimes as we get older, we just can't sleep through the night for whatever reason. Can you take a nap during the day? Right? Put it together. If you feel rested, that's a good thing. Because if you're feeling rested, then your brain is not sluggish. It's not tired. And you're able to focus better. You're able to feel better. So even though we'd love everybody to go to bed at 9 and wake up at 7, you only have to get up twice to use the bathroom, right? We know that it's not always possible. But if you're feeling sluggish, go ahead and give yourself permission for that nap, okay? And avoid the things. My grandmother, and this was a while back, my mom had called me up, and she was laughing. It was her mom. She says, your grandma decided she wanted to see what the big fuss about Mountain Dew was. So she had one for dinner. Yeah, everybody sees it, right? So at 4 in the morning when she was still awake, lying in bed, saying, I'm never drinking that stuff again, because she'd had a stimulant, too much caffeine, too late. And what they're saying is, the stimulants, don't have them past 2 o'clock. Don't have caffeine, don't have sugar, right? If you're having trouble falling asleep, cut back earlier during the day. The other thing is, for good sleep hygiene, if you're lying in bed and it's been 20 minutes and you're not falling asleep, it's time to get out of bed. Because 20 minutes, what happens is our brain, which is this amazing thing, our brain starts to associate laying in bed awake instead of laying in bed asleep. So if we're lying in bed and we're awake, we're telling our brain it's okay to be awake in bed. If we want to be asleep in bed, and that's the activity that you want in there, you can have other activities too, but I mean, if you're going for rest, and if you're not sleeping in 20 minutes, get up, go do something else. You can do the dishes, you can watch TV, you can read, you can work on a jigsaw puzzle, anything at all. Wait until you start to get that drowsy feeling, then go back and try again. And if you do this consistently for a couple weeks, you're training your brain, that habitual part of our brain, which we like patterns, we like habits, your brain will start to respond. Create joy and satisfaction. Can't tell you how important this is. Even if it's things that you used to like, but you don't think you like anymore. If you can't come up with something that brings you joy, go back to what used to. Maybe it'll surprise you. Maybe it's something from your childhood. I like to color. When I was a little kid, I liked to color. Well, we all know that these adult coloring books are all over the place, right? Mm-hmm. There's a reason. People like to color. We want to make sure we can get inside the lines. Or if you're a rebel, you go outside the lines, right? But if it makes you feel good, do it. Because there's so many things that bring us down. We want to try to lift up. We got to find a balance, right? Put on an old TV show, an old comedy, an old movie. Look at pictures, photographs, and call up somebody in the family who remembers. Remember that time when we went up to the ski slope and you were halfway down the mountain and your skis came off, but they kept going and you had to walk all the way down? That was the funniest thing I ever saw, right? They may not think it's funny, but if you do, that's all that matters. All right, eat well. I mean, the stuff our doctors have been telling us, exercise, get sleep, and eat well, these are the tried and true. If you're feeling sluggish, what's in your diet? What can you add to it? What can you take away? The internet will tell you every kind of diet that you need to have. More energy, less energy. I was going to say, more gas, less gas. Whatever. If farting makes you happy, have those beans, right? But the idea here is you really want to make sure that you're eating right. Water, lots of water, right? Make sure you have it. Take care of your spirit. If you're religious and you have a faith and you're able to take care of your spiritual needs through that avenue, great. If that's not your cup of tea, fine. But what is? Is it going outside and just listening to the birds, right? Is it reading a book about a guru, or some different religion that maybe we don't have in our community? Okay? It's whatever works for you. But make that connection. Remember, we are spiritual, we are physical, we are mental cognitive. That's what makes us up. Deal better with hard times, so coping tools. And this is where you may need some help. Self-help books are out there. Talking to a pastor, a minister, talking to a professional counselor, and saying, I need help to figure out how to get through these times. My health issues, loss, change, feeling sad, I don't know how to deal with it. There are so many different tools that are out there. Don't be bashful. find some that work for you. Because what works for you may be different from you, which is different from you. But if it works, if you find something, when you find something, that's the best. And then, of course, get professional help if you need it. I love Eeyore, and I love this. It says, one awesome thing about Eeyore is that even though he's basically clinically depressed, he still gets invited to participate in adventures and shenanigans with all his friends. And what is amazing is that they never expect him to pretend to feel happy. They never leave him behind or ask him to change. They just show him love. And I thought this is the best slide that I've seen in so long, because it really helps us to understand that when someone is depressed, they still want to be a part of things, and they still need to be a part of things. And what they need most is our support and our love. And this slide is right. Eeyore is the exact personification of how we should treat people who are depressed.
It also said, it also kind of implies that if all your friends are not doing that, then you need to have different friends.
Different friends, or maybe educate our friends too.
You can educate.
Sometimes what friends need to hear is what you need.
The truth.
The truth, right. I'm depressed, and I can't just change it. I can't just, when I hear, well, at least the sun's out today, that doesn't make me feel better. I literally, the lady that I was working with a couple hours ago, she said, my friends say, well, at least the sun's shining. She goes, that doesn't do anything for me. No, what she needs to hear is, I'm sorry you're feeling bad. What if we just sit together? Right? So, sometimes we have to educate. How to determine when to seek help. So we talked about the blahs, we talked about the blues, we talked about depression. To get a proper diagnosis, you really do need to go through a doctor or a trained professional, like a counselor. And typically, if the person is in an assisted living facility, the care workers might see something's wrong first. Family might see things wrong first. Again, trying to figure out, is it a physical issue? Or is it a cognitive issue? Or is it a mental health issue? That's difficult. So a mental health expert is going to assess and look at symptoms, mood, behavior, day-to-day activities, family history. They're going to ask how long it's been going on. They're going to ask how you experience it, what you're experiencing, what's changed, what you've tried. And then they're going to, talk about treatment and what options are available. So medication, talk therapy, self-help, right? Or going back and go to your basics. What's made me feel better in the past? There's a therapy type called positive psychology, and it was invented by a man called Martin Seligman. And he still has, an entire university section where he talks about positive psychology. There's been a lot of research done on it. And his whole theory was that in counseling, we've always looked at what's wrong. But we also need to be looking at what's right? What's working? And everybody has gotten to this point in their life somehow. We've all survived it. We've gotten through everything. Everything that's come to me, I've somehow managed to get through it. So I have skills and knowledge and experiences and abilities. And I know that because I'm still here. And so what I can do is use those skills and knowledge and education and bring it forth and apply it to the situation I am now. And that's where being older is so cool, because we got a lot more to pull on, right? So one of the things positive psychology says is look for your daily gratitudes. Look at the things that you're grateful for, the things that help you get through. It might be the lights work. Now, we would expect that to happen, right? But when they don't work, we certainly know it. So why not give it credit when they do work? The earlier example, I can stand up from a sitting position to a standing position, and I don't always fall. I can be grateful. And then there's this Pickles cartoon. So they're sitting here, I'll read it in case you can't see it. He says, I didn't brush my teeth with Bengay this morning. The shower head didn't fall off while I was taking a shower. And I didn't lock myself out of the house getting the morning paper. Yeah, it's been a good day so far. Right? It's the perspective in which we look at it. All right, depression and anxiety are treatable. You do not have to suffer. Treatment options are many, and it's never too late to work on feeling better. Any questions?
They tie in depression and anxiety together. And yes, what is your description of anxiety?
So clinical anxiety is a pervasive worry, worrying about many things throughout each day, and this is a daily experience. Feeling tired, fatigued, right? Difficulty concentrating, okay? And feeling hopeless or helpless. So these are feelings, you can't get past them. They're just kind of there. And it's really that I'm worried about this, and I'm thinking about that, I'm thinking about this, and I'm thinking about that. And sometimes the brain won't shut down, right? Ever feel like a ping pong in a wind tunnel?
Yeah.
Right?
That's what I tell my husband. He'll ask me a question, and I say, my brain's doing this, I can't answer you.
Yeah, yeah. And what I would say is if you're taking medication, talk to your doctor or the pharmacist. So here's a hint. Pharmacists go to pharmacy school for all of those years, and they only focus on pharmacy stuff. Doctors go to school for all those years, and they focus on a lot of stuff. If you have a question about a medicine, talk to a pharmacist. You know, have that conversation. Not that they can prescribe things, but they can educate you. And they can say, oh yeah, well, you're taking this and you're taking that, and here's a chemical connection. You know, and they're going to spot it probably before a doctor will, because that's their specialty. So if you're taking medications and this is a newly developed thing, newly in the last few years, then I would say there might be a medication that is creating some of that racing thoughts or difficulty concentrating. If not, then I'd say, you might need an assessment. See what else is going on. Yes?
Can I grief or loss of loved one cause depression, anxiety?
Absolutely. Absolutely. So it used to be grief and loss, and can that cause depression or anxiety? And the answer is yes. When doctors go to diagnose, they have something called the physician desk reference, the PDR, right? That's where they get all their diagnoses. For people in mental health, we have the DSM, the Diagnostic Statistical Manual. We're on the 5th edition. My dad, when he went to school, he had the first DSM. It was that big and about this big, right? My DSM-5 is this thick, right? And it's that big. So we have a lot more diagnosis, which just means, like everything else, we've learned more, we've researched more. Instead of saying everybody who sneezes has this diagnosis, now we're saying, well, if you sneeze and you cough, you're this one. And if you sneeze and you cough and a sore throat, it's that. They just divide it up. Going back to that. Grief used to be part of the DSM, complicated grief. And it basically said that if you had complicated grief, that was symptoms of grief that lasted more than 6 months. And if you had that, that was considered abnormal. Currently, the very smart people around the world who study grief have said there's really no timeline. And so they've removed that. There is no complicated grief, there just is grief. And now what they say is, if you are experiencing grief and it's disrupting your life in a way that makes you uncomfortable or you feel you need to work through, that's a good enough reason to want to work through it. So there's no time limit involved And people can be depressed for years because of grief. Yes.
I just wanted to clarify one thing for myself.
Sure.
What is the difference between we're not gonna put you away and we need to protect you?
Oh, that's a really big question. Are you talking specifically for suicide? Or are we talking about anything? Well, it can look different, right? For cognitive, so I am not an adult protective service worker. I've had some trainings. And in the state of Michigan, if you are at risk to yourself, or you are at risk imminent harm to yourself or someone else, that could trigger an intervention from 911, from Adult Protective Services, whatever it is. They're going to come in and they're going to do assessments. First of all, they're going to make sure that there's no imminent risk in the moment, right? There's nobody with a razor blade to their wrist. There's nobody walking down the highway because they're confused and they think they're going home after school. So as long as a person is not in imminent risk of harm, then that gives them time to assess the situation. Physically, is there something going on? UTIs, urinary tract infections, can cause people to have hallucinations.
I just learned that.
Yeah. So we can have infections, very simple infections, that because of the medications we take or simply our aging bodies, it triggers an event in our brain and we're not aware. We're not completely alert and aware of the situation, our reality. So in those cases, you treat with an antibiotic, they feel better and all's good. So you treat and you assess the physical. Then you look at the mental. If someone is suicidal, you start getting them treatment. Maybe they stay in the hospital for a day or two so that they can get medication and those thoughts of wanting to harm themselves go down, because then you can work with it. If it's cognitive, it's, Mom, you're making bad decisions. Mom, we're worried about you. You're gonna be hurt, or we really think you need to be somewhere. That's much more complicated. Because again, going back to Adult Protective Services, when they do the assessment, what they're looking for is that the person understands what the potential risks are, and they understand the consequences or potential consequences. When I get in the car and I'm on the highway and the posted speed is 70 miles an hour and I go 75, I'm making a bad choice. Because the posted speed limit is 70. I'm risking a speeding ticket, and I'm risking, if there is an accident, somebody somewhere said 70 is kind of the fastest you want to go. 75 is more dangerous. I understand that. My mind allows me to understand that, and I accept the consequences. If I'm driving down the road and I'm doing 100, and somehow I stop and someone comes up to me and says, "Do you know what you were doing?" And I said, "Yeah, I got that needle to go to that 100. Well, you could have been killed. No. My grandkids play this game and they do faster than that all the time. It's not a problem. Well, they crash, don't they? Yeah, and then you just hit reset, and then you go again. That would be an indication that my brain is not aware of the consequences. And they would say, you don't get to drive. Okay? So I'm kind of making extreme examples here. But this is kind of what they look for. Do people understand the risk and the consequences from the risk? And if it's deemed that they don't, then yes, for their benefit, they could make decisions for them. But that takes going to court. And then a judge looks at like reports and everything else and makes determinations a lot of times.
No, it's decided for you in the hospital.
But it doesn't have to stay that way. So if you are in a nursing facility.
No, I'm not talking nursing.
Okay. Are we talking,
I'm talking about a hospital.
okay. Psychiatric hospital?
No, just a hospital. And then they pick up on that stuff.
Okay. I would have to know a little
And they
bit.
look at your history, and they do all this stuff that,
Yeah.
and they determine you as a risk.
A risk still, you still have patient rights, recipient rights. They are there. If no one has talked to you about it, it doesn't mean that they're not there. And maybe we can talk afterwards, and I can give you some directions. Okay. There is something called the Long-Term Care Ombudsman. This is an office in the state of Michigan where they look for rights of people to make sure that people are not being kept in places where they don't belong or they don't want to be. If they're able to. Any other questions? Yes.
Is there a price for your services?
So counseling services, I'll talk broadly. So counseling services, mental health services are offered through your Medicare Part B. That is just like you can go to a doctor, you can go to a mental health professional. So psychiatrist, psychologist, social worker, we are covered, and then it depends on the insurance that you have. So if you have traditional Medicare, it's covered 80%. If you have a supplement, they'll pick up the other 20%. Otherwise, it's your copay. If you have an Advantage plan, I'd say contact your Advantage plan, the number on the back, and say, what is the coverage for outpatient counseling? And they will tell you exactly what if it's a copay or if it's covered.
Okay, thank you.
You're welcome. Any other questions? Well, thank you very much. I appreciate everybody letting me come in and talk to you today.
Thank you for having the courage, being here today and being vulnerable. We do appreciate it. If you ever want to get a hold of Julie for any reason, I do have her contact information. I do want to share some of the things that we do here at the center, because on that one page for the tips for mental wellness, we do a lot here at the center. We do, and I'm very proud and very honored to be here and very grateful. I love being grateful. So I went through a depression area myself in my lifetime not too long ago. Well, I guess it's been about 10 years ago now. Or when I started, then I got out of it. So I've been out of it for 5 years or 6 years. I don't even know. I don't even count anymore. I'm just happy. And those positive affirmations are really great. I used to write down, I am happy. I am loved. I am loved. I'm lovable. I used to write those things down because I didn't believe them. And all this stuff does work. And you have to do a lot of things and everything. So it's really important that you do what you can do. And it's hard. And I know that. I get really emotional because I remember those feelings and those moments.
One good thing to do is to sit down and write down a lot of things that you're thankful for.
Yeah.
And that can make a difference.
Yeah. Do you have like a thankful journal? Absolutely. Gratitude journal? Yes. Yep. Yep. That is, yeah. I start my day like that, so yes. But here at the center, we have a group that we have just started called People Inspiring People. It's the first Friday at 11 o'clock of each month. We sit there and we just we talk about things. We have talked about gratitude. We talked about love. We talked about the love languages. We talked about, our topic this month was about going to spring and how that is part, we come out of hibernation and creating and how we can use that. We also find ways to get back to the community. Right now, we are working on a project to make Mayflower umbrellas out of paper plates and decorated them to give them to the Buchanan Meadows as well to our senior nutrition services, people who get food. And we're going to be having some classes in April. Watch the newsletter when that comes out. It's just an art class, make 2 to give, take 1 home. So that way you can kind of help to give back and to participate, to socialize. We have a book club, we have quilting and sewing, and we have Fiber Friends. Those classes are really important because we are socializing, and we are sharing, and we are creating, we're doing things, we're talking. Exercise programs, we have cards and games. Always hear laughter when they're playing. You can stop by, grab a cup of coffee. We have some people just come here, they could grab a cup of coffee, they sit down on the tables, and they just chat for a while. So stop on by. It's the time of the year now. We're going to be adding more programs. I have field trips planned. We have walk days planned. So, I know some of you might be limited, but also just think about going out of that box. And I know it's hard, but just to start to do it. We are here. We have fun. If If you need a hug, I'm always a hugger, so I'd be more than happy to give you a hug. But again, Julie, thank you, thank you, thank you. This program is very personal for me, and I'm so glad that Julie was able to bring it. Great information. Thank you so much.
You're very welcome.
And thank you, like I said, pat yourselves on the back for being here today. Enjoy, everybody. Blessings. Have a great day.
And I did put my cards back on the table, so if you want to grab a card, help yourself.